let me introduce about Vishwa Ayurved Parishad. Vishwa Ayurved Parishad is the largest Ayurved organization dedicated to empower practitioner, academician, and all Ayurved stakeholders. So it is established in 1997 by Yogesh Chandra Mishra and Usalkar and his colleague, four other colleagues. It has got branches in 6 countries and 36 states. So it is the largest Ayurveda organization in India. So we used to celebrate Vishwa Mangal Divas on Sankranti, Pratipada Divas on New Samvatsar, Charak Jayanti on to dedicated to Charak Maharshi Charaka, and we also organize a big event called as Laksha. So it's a mock pre-PG test to empower PG students, those who are seeking for PG entrance examination. Another one is Dhanvantari Divas. So these all the 6 activities, and we also award different essay competitions for UG, PG, and dissertation awards also. So now regarding this lecture series, we already conducted 15 Panchakarma webinar series. So now on Woman Viration, we will almost cover all the topics. Now there is challenge regarding MD preliminary syllabus. So in third module, there is CT, MRI, radio diagnosis, and hematological investigations. So in Ayurveda practitioners, we are lacking in these skills. So as to empower this, we arrange this lecture. Now let me introduce Dr. Shibu Varghese. Shibu Varghese is professor and head Naganelli Ayurveda Medical College, Kothamangalam, Ernakulam district. So he also Senate member of Kerala University of Health Science. It's his third generation Ayurveda practitioner. His father also a B.A.M.S practitioner. They're running Kalarickal Ayurveda Hospital at Kothamangalam, and apart from that, he is also deputy superintendent of this Naganelli Ayurveda Medical College. He published book on bird eye view on investigations. So he covered this book is its fourth edition. Gradually, he added some topics depending upon depending upon the demand of the PG students. So now this book covers almost all the topics. You observe that in third module, blood investigation and their clinical importance is also there. Apart from diagnosis, blood investigation is there. So I request Dr. Shibu Varghese to share his views on uh, CT, MRI, radio diagnosis, and sonography. Over to Shibu, sir.
Uh, Chavan sir, good evening.
Good evening, Shibu, sir.
Sir, am I audible, sir?
Yes, you are audible.
Yes, sir. Yes, sir.
Okay. Whether my screen has come, it has got shared. Sir, whether my screen is visible to your screen?
Yes, sir. Yes, sir.
Yes, sir.
Okay, okay. So, can I start?
Yes, sir.
Okay. Very warm good evening to all. Most respected Dr. Santosh Chavan sir and the other members of Vishwa Parishad. So the topic which has been given for me today is a role of CT, MRI and sonography in diagnosis. So as you know, in Ayurveda it has been said that Rogamadav Parikshite Tadanantaram Aushadam. The slogan emphasizes the importance of clinical diagnosis before the treatment. So our Acharyas has made use of the available technologies available at that time to explore the total picture of the disease. For example, Taila Bindu Mutra Parisha. That's one of the diagnostic tool which they used at that time to explore the total picture of the disease before starting the treatment. So now for us, there are a lot of, in the investigation area, there is a quantum gem and there is a lot of investigational tools are there for us to make an accurate diagnosis. If we fail to use those investigative tools, definitely patient will not approach to an Ayurvedic doctor. Now, it's a plight of the Ayurvedic doctors that actually we are not very much trained in the diagnostic areas, even though the present syllabus offers some insights into the diagnostic area, but so far the diagnosis has been not given much importance. But the present day clinical practice without the proper investigational backup is never ever imaginable. So in this topic, it has been given the role of CT, MRI, and sonography in the diagnosis. So the imaging plays a bigger role in diagnosis, along with the hematological investigations. Nowadays, not only the clinical examination, but imaging also plays a major role, especially in Ayurveda doctors. We deal more with the musculoskeletal disorders. In musculoskeletal disorders and trauma, this CT, MRI, and sonography is of very much importance. So the Pancharma PG curriculum also has given an importance on how to read CT, MRI, and sonography. So CT, MRI, and sonography, even that sonography to learn through this is slightly difficult. Only I will be explaining about the applicability of sonography. But MRI, I'll be focusing more on the MRI, and along with that, I will be giving some insights about CT also in the lecture. So first, I will be dealing with the MRI. And the slide is not changing. Slide is not changing. Okay. As you know, the MRI scanner is a medical tool that uses strong magnetic field gradients, and radio waves to generate images of the organs of the body. So, I repeat, MRI is a scanner which uses a magnetic field, radio waves to generate the anatomy of the body. Nowadays, it's not only the anatomy, even the physiology also can be understood with the help of an MRI scanner. But basically, it uses a magnetic field, the radio waves, to generate the image of the body. So, as you know, X-ray, X-ray has been invented by William Conrad Roentgen. So, he is a single person who has invented the X-rays. But as far as an MRI is concerned, it has not been invented by a single person. But MRI, the MRI, which is used for the medicinal purpose, has been invented by the great scientific minds, or the tale which views through 2 centuries. It's not really a single person or a single year or 100 years, but it views through 2 centuries. The first invention came in 1882 when Nikola Tesla explains the rotating magnetic field. So, as you all know about the Nikola Tesla. He is the unsung scientist of the century. He has invented many things. Among that, one of his greatest invention was the rotating magnetic field. So, that is the base for the invention of MRI scanner too. So, the next significant discovery came in 1937 from the Columbian University by Professor Isidore I. Rabi. Along with him, in 1946, Felix Bloch at Stanford and Edward Purcell from Massachusetts Institute of Technology discovered a phenomenon known as nuclear magnetic resonance. So, after 1882, in 1937 and 1946, these 3 scientists discovered a new technology called as nuclear magnetic resonance. So, with the help of this phenomena, they have identified to understand the structure of the molecule. That's the second phase of scientists who developed the nuclear magnetic resonance. Then, till 1971, the NMR technology was used to analyze the chemical as well as chemical features of the molecule only. In 1971, came a doctor called Dr. Raymond Demerdian. He understood that suppose if a patient has got a tumor in the body, the tumor contains too much of water than the normal organs. So this water contains more of a hydrogen atom. So with the help of this NMR technology, he found that if we invent a scanner, these tumor cells can be identified with the help of a scanner. So he discovered a scanner in 1971 called as Indomitable. So this is the first scanner ever discovered in the history. So this is the scanner is so big because it uses a very big magnets for that. And this is his colleague, and he has tried to scan a part of the body. But one of the two problems is that he could take scan only a 2D images. The 2D image was too crude and it takes too much of time for a scanning. So the scanning didn't came proper. So the next came a scientist called Paul Latober from New York. He identified that if you use a gradient coil this magnetic field, to this magnetic field, 3D, 2D images can be generated, and from that, with the help of a computer, 3D images can be generated. So with the help of a Paul Latober, they discovered a 3D images from a scanner. But still there was a problem of time. If you want to scan a single part, it took hours to scan a particular organ of the body. So to solve this problem, Peter Mansfield from London, he discovered a phenomena called the line scan technology. With the help of a line scan technology, we could scan a part of the body within a matter of 20 minutes. So he has scanned a finger within 20 minutes with a better precision. So this is how the scanner MRI has been discovered, starting from the Nikola Tesla to the Peter Mansfield. Nikola Tesla discovered a rotating magnetic field. Then the second phase of scientists discovered the NMR technology. Then Raymond Damodian discovered an indomitable scanner, but the 3D images could not be produced. So Paul Latober discovered the gradient magnetic field, so 3D images could be made. And Peter Mansfield discovered a line scan technology which overcome the time constraint of the MRI scanner. So that's how the MRI what we use today has come. So in this picture, you can see two MRI scanners. One is the open MRI scan and second is the closer MRI scan. The closer MRI scan gives a better precision of the images, and open, because in the MRI, one of the major problems is that those who are having a claustrophobia could not get a proper scanning because they develop a fear when they lie inside this closed scanner. For them, there is a scanner called the open scanner. So there are two types of MRI scans available. One is the open as well as a closed scanner. So this is the cross section of an MRI. What you can see, this is the cross section of the MRI. So the patient is made to lie down inside a gantry, and the gantry is covered with big blocks of magnets. It's a very powerful magnet covers the patient. Along with that, there will be a gradient coils will be there, and a radio frequency coil will be there. So normally what will happen, the patient is made to lay inside a gantry which is having a strong magnetic field. Then a radio frequency coil is there that emits the radio waves. So the radio waves will be sent to the patient, and then it has been received with the help of certain receivers present in the scanner. This is a cross section of an MRI scanner. So let me tell you about the basics of an MRI. So normally when the patient is made to lie inside the gantry, inside the gantry it is a strong magnetic. So patient is made to lie inside a strong magnetic field. So our body contains hydrogen, and the hydrogen contains even a smaller particles called the proteins. These proteins are just rotating in a haphazard manner normally. So when the patient is made to lie inside the gantry, what will happen? The protons will start align in the same direction of the magnetic field, like a compass aligns with the magnetic field. So as the patient is lying inside, the protons are lying in the same direction of the magnetic field. Then short bursts of radio waves are sent to the body. So when the short bursts of radio waves are sent to the body, what will happen? This protons will starts to come out from the magnetic field and starts rotating in a very haphazard manner. In any direction, starts rotating. So at one point of time, what will happen? The radio frequency pulse of the radio waves and the protons will be in a similar manner. So at that time, the protons will receive some energy from the radio waves. Then the radio waves are switched off. When the radio waves are switched off, when the protons will give back the energy which is absorbed from the radio waves, and these are being picked with the help of a receivers. And every part of the body will send the particular radio waves, which has been the energy taken from the radio wave, and it is given back. And that has been picked with the help of a receivers, and the 3D images are constructed. I'll repeat once again. When the patient is made to lie inside a gantry, because the inside the gantry it is a strong magnetic field is there. When the protons are made to lie exposed to a magnetic field, it aligns in the same direction of the magnetic field. Then certain radio waves are sent to the body. The radio waves will knock the protons out of the alignment. This radio waves will knock the protons out of the alignment, and the protons will start rotating in a very indifferent manner. So when the radio frequency pulse and the protons of the same energy, what will happen? What happen? These protons will pick up the energy from the radio waves called using a phenomenon called as resonance. So because by the phenomenon called resonance, the protons will receive certain energy from the radio waves. Then the radio waves will be switched off. When the radio waves is switched off, what will happen? The protons will give back the energy taken from the radio waves, and it has been absorbed. It has been taken with the help of the receivers, and the 3D images are constructed. This is how an MRI image has been taken. So as you know, in X-ray, what will happen? X-rays will penetrate through the body, and it falls on the film. Here it is not like, it is not a reflecting back. What will happen? Every organs of the body will give away the energy, so that there is no, suppose in an X-ray, what will happen? If some structure is there in the back of a heart structure, that will not be reflected. Here it is not like that, because every organ will send the images. So a clear picture of each and every part can be scanned with the help of an MRI. Now let's see what are the applications. Especially as we Ayurveda doctors deal more with the musculoskeletal disorders, the spine anatomy is more important. So in the MRI, spine anatomy and alignment can be better discovered. Birth defects in the vertebra like spina bifida occulta, spina bifida meningeal, spina bifida myelomeningeal, etc. can be very well seen. Any birth defect like fracture of the pars interarticularis, anything can be detected with the help of an MRI. Then trauma injury to the bone, like suppose if there is a compression fracture, if there is a compressive myelopathy of the cord, if there is a ligamentous injury, etc. These can be seen with the help of an MRI. Then disc and joint disorder, if there is a disc bulge, or if there is a discitis, if there is a facetal joint arthropathy, etc. These can be seen with the help of an MRI. Compression or inflammation of the spinal cord and nerves, if there is a compression fracture which results in a myelopathy, or if there's too much of compression leads to myelomylacia, etc. can be seen in the MRI. Or if there is a compression by the disc on a exiting nerve like spinal sciatic nerve, etc., that can be seen with the help of an MRI. Infection of the vertebra. Suppose if you have got osteomyelitis, either tuberculosis osteomyelitis, brucellosis osteomyelitis, any infections, Staphylococcus osteomyelitis, any infection on the bone can be seen with the help of an MRI. In the tumors of the vertebra, if there is a tumors of the vertebra like multiple myeloma, osteosarcoma, spinal cord tumors like astrocytoma, ependyma, hemangioblastoma, etc., can be seen with the help of an MRI. So these are the applications of MRI scan. Then what are the benefits of the MRI scan? So today we'll be discussing about the CT and MRI also. CT, as you know, it involves a lot of radiation will be there. But MRI does not involve any radiation, does not cause any harm to the body. So MRI is a non-invasive imaging technique because it does not, we don't want to go inside the body like endoscope or something. From external itself, we can screen that. MRI images are more clearer and more detailed than with the CT scan, etc. MRI can detect abnormalities that might be obscured by bone. In CT, one of the problems is that if some bone is obscuring the other bone, it will not be seen on the CT. Also, some lesions which are very near to the skull, etc., cannot be seen in the CT. But MRI can detect all those things because there is no matter of obscuring, because each and every structure is releasing the their own energy on their own images. It is not like that. It is not reflecting. So each and every part can be better screened with the help of an MRI. Also, the contrast. Suppose if we suspect a tumor or a demyelinating place, we use a contrast. So in MRI, we use a gadolinium contrast, which is a paramagnetic ion, which it does not cause any of the complication. But in CT as well as X-ray, we use iodine-based contrast, which can lead to renal failure and other cytotoxic effects. So MRI contrast is comparatively safer. Also, MRI is very useful for evaluating spinal injuries. It rule out acute spinal cord compression, etc. Also, MRI is able to detect subtle changes in the vertical column. Like actually, suppose if there's a tumor is of 0.5 centimeter size, because CT, if you want to screen some tumor, it has to be above 0.5 centimeter. But in MRI can screen, which is much lesser than 0.5 centimeter. So even a smaller changes can be detected with the help of an MRI. MRI is more sensitive than CT in scanning for evaluating tumor, abscess, and other soft tissue masses near the spinal cord. Any lesions near to the spinal cord can be better screened with the help of the MRI rather than CT. That's it. That's about the benefits of MRI. So the precautions, whenever we go near to MRI scan, we should not bring any metallic items near to the MRI because it contains strong and very powerful magnet which can attract even bigger metals to that. So that's one of the major precautions. And then if you advise a patient to go for an MRI, you should advise them not to carry any jewelry, watches. If there is any jewelry on the body, it will become heated and it can lead to burns. Watches, if there's electronic watches, it will be damaged. If credit cards, as you know, credit card contains a magnetic strips is there. How much lakhs of money is there in your credit card? Also, if you take it near to the MRI scanner, it will become blank. And certain hearing aids, all this will be damaged. Then pins, hairpin, metal zippers, etc. Then certain removable dental was, then body piercing, mobile phones, electronic watches, etc. should not be. Then certain cochlear implants, certain aneurysm. But nowadays, most of the or the clips which are using inside the body are MRI safer. The older ones were not safer, even cardiac defibrillators, pacemakers. Nowadays, even the pacemakers are safer with the MRI. And certain metallic coils which are used to place to manage these aneurysms, etc., can cause complications while taking an MRI. So these are the precautions to be considered before taking an MRI. So if you want to read MRI, there are basically three terms are there. One is sequence, signal intensity, and gradient. Let us see what you mean by sequence. So MRI has got T1 weighted. So as I said, when we switch off the radio wave, what will happen? The body will give away certain energy. The radio waves will be sent back. So that release of the energy will happen in two constraints. One is a T1 weighted constraint and T2 weighted image. Because every organ from the bone, it releases certain energy. That the time duration for releasing the energy from the bone and the blood will be different. So it has been taken with the help of the T1 weighted image as well as T2 weighted image. These are the two sequences. Then there's one more sequence called the fat suppression image. Suppose if on a vertebral body, if we find a hyper-intense lesion, we don't know whether it is an edema or a fat, it is very difficult to differentiate. In that condition, we need to use a technology called the fat suppression image, where fat will be suppressed. So if even after the fat suppression, if hyper-intense lesion is noted, then it is a edematous fluid. Then MRI contrast. These are some contrast material will be injected into the body to screen whether they, suppose in case of multiple sclerosis, whether the plaques are active or not. If there's a tumor, if the tumor is present, because tumor takes up more of the contrast material. So these are the major sequences: T1 weighted images, T2 weighted image, fat suppression, and MRI contrast. Then PD weighted gradient is there. For a baseline study, these sequences will be enough. Let us see how to differentiate T1 weighted image and T2 weighted image. So T1 weighted image, the first picture what you can see, it is mainly to study the anatomy of the body, and T2 weighted image is mainly to study the pathology of the body. I repeat, T1 weighted image can give a better description about the normal anatomy, and T2 weighted image is better to analyze the pathology of the body. Then second is how to differentiate between T1 as well as T2. Just observe the cerebrospinal fluid. Any fluid appears black in T2, and in T2 it will be white or it will be hyper intense in nature. So that is how we differentiate between a T1 as well as a T2. But the fat, you can see the adipose tissue or fat tissue. Fat appears brighter in both T1 as well as T2. It appears white in both T1 and T2. But cerebrospinal fluid will appear black on T1 and white on T2. So T1 is mainly to assess the anatomy, and T2 is mainly to assess the pathological condition. Then muscles will appear gray on this, and in the T2 weighted image, it appears a little more dark gray. Spinal cord appears gray in the T1 and light gray in the T2. So this is how a T1 as well as T2 image is taken. Next is views. In X-ray, you know, there is anterior views there, lateral views there. Likewise, in MRI, there are basically three views are there. One is the sagittal view, axial view, and coronal view. In the sagittal view, suppose if you want to take a study of a banana. So this is the sagittal view. It is very similar to that of a lateral view. And the bottom up view, or this is called as axial view. And if you remove the peel of the banana, what you see, that is the coronal view. That is very analog to AP view. The sagittal view is analog to lateral view, and coronal view is analog to AP view. So this MRI, you can see this is a sagittal view. Here you can see, like how we cut a cadaver, the same image can be obtained in the case of a sagittal view. This is called as a sagittal view of a banana. So in X-ray, you will be having only one slice, but in MRI, there will be multiple slices will be there, taken from left to right in a matter of 3 millimeter. Every 3 millimeter, we can slice the vertebral body. So sagittal view is very analog to lateral X-ray. And in sagittal view, mainly there are three sagittal views there. One is a mid-sagittal view. What you can see, this is a mid-sagittal view. This is a parasagittal view, and this is a foraminal sagittal view. There are basically three sagittal views there. The sagittal view, mid-sagittal view is in the MRI is sliced at the central part of the vertebra. And the parasagittal view is that it is slightly medial to, again, this is slightly again medial to the central, and this is more medial. This is called as parasagittal. This is called a foraminal sagittal. This is a parasagittal view. So in the mid-sagittal view, you can see the spinal cord, and the spinal nerves can be seen, and all the vertebral vertebrae as well as intervertebral disc can be clearly seen in the mid-sagittal view. The parasagittal view, the disc bulge can be better seen in the parasagittal view. Here you can see the disc bulge, because the disc bulge occurs more at the because the central disc bulge is quite less. Only paracentral disc bulge is more common. So paracentral disc bulge can be better viewed in the parasagittal region. Also, these are the pain sensing nerves. What you can see, these are the pain sensing nerves. If there is a compression of the disc on the pain sensing nerve, that can be better seen on the parasagittal view. And third is the foraminal view. Here you can see the black one. What you can see, these are the exiting nerves. Suppose if there is a disc bulge into the foraminal view, that can be better seen in the foraminal view of the sagittal region. So these three views are, it is very easy to read these three views, because in this mid-sagittal view, spinal cord can be clearly seen, spinal nerves can be seen. In parasagittal view, the disc bulge can be better seen. In the foraminal view, whether the exiting nerve is compressed or not can be better seen on the foraminal sagittal region. Then axial bottomy, like how we slice a bread actually. What you can see, if it's likewise, if you slice the vertebra, this is called as axial bottom view. So even though axial bottom view is very difficult to understand, but it gives the maximum information about the vertebra. Here you can see the disc can be seen, the disc bulge can be seen. This is the spinal cord. This is the spinous process. This is the lamina. This is the facetal joint. This is the ligament of flavum. So all this maximum information can be obtained with the help of an axial bottom, even though it is slightly difficult to understand that, but it gives the maximum information about the condition of the spinal cord, the spinal nerve, the disc bulge, the facetal joint, the ligament of flavum, etc. can be better understood with the help of an axial bottom-up view. This is a coronal view. Here you can suppose if there is a scoliosis, that can be, it's very analog to the AP view of the X-ray. If there is any scoliosis, that can be seen, or certain Tarlow cyst, etc. can be seen in the coronal view. It's very analog to AP view, and compression fracture can be seen. All these things can be seen in the coronal view. So basically, I repeat, there are basically three views. One is the sagittal view, axial view, as well as coronal view. These are the three views in an MRI. This is MRI of the cervical spine. Simply, suppose if a patient complains of pain in the neck, you should not send for an MRI. There are certain clinical indications are there. There are always certain clinical indications when to send for a cervical spine MRI. That's very important. You should understand that. You have to follow this protocol properly and don't send the MRI simply. So one protocol is absent or reduced sensation or clinical. Suppose when the hands or back, when you do a sensory exam, if there's a sensory impairment, normally in case of syringomalia, or if there is a spinal canal stenosis, etc., there can be a sensation will be absent. So if there is a sensory loss, is there, it is an indication for an MRI. Absent or reduced reflex, when you take a biceps or triceps reflex, if the reflex is absolutely absent or a reflex is there, that is always an immediate indication for an MRI. If there is a muscle wasting or if there is an atrophy of the muscle shown on the shoulder, hypothenar area, etc., that is definitely an indication for an MRI to rule out whether there's any compression or not. Next is severe intractable arm pain where symptoms have been present more than 6 weeks. Suppose if the pain in the neck radiates into hands, if it is persisting more than 6 weeks, if it is in the first week or second week, should not refer for an MRI. If it is persisting more than 6 weeks, then only we should send for an MRI. Then axial neck pain. Suppose if there is a pain on the neck at a particular point, if it is greater than 3 months, if at a particular point, if the pain is persisting more than 3 months, then it is an indication for an MRI. If there is a reduced power on physical examination, when you go for a physical examination, if there is a reduced power on the hands, if there is instead of grade 5 power, if the patient is having grade 2 or grade 3, then that is an indication for an MRI. Or if you suspect a CNS tumor infection or inflammation, suppose if there's a pain with a fever, etc., if you suspect an infection, then you have to send for an MRI. If you suspect an inflammation, rheumatoid arthritis, if you suspect a atlantoaxial inflammation like B.A.M.S formation, etc., then that is an indication for an MRI. Then if you suspect a congenital malformation of the spinal cord, like spina bifida occulta, spina bifida meningocele, myelomeningocele, etc., then any trauma, if there is a trauma which causes a weakness to the hands or legs, etc., that's an indication of an MRI. So my request is that don't simply send a patient for an MRI. Please follow these guidelines. Main guidelines: if there is a pain radiating to the neck which is persisting more than 6 weeks, if there is a pain at a particular area which lasts more than 3 months, if there is a reduced sensation, if there is a weakness of the limbs, if you suspect some infection or something, then only send for an MRI. Simply don't send for an MRI. Next is, as far as cervical spine is concerned, T1 weighted image, axial and sagittal, T2 axial and sagittal. Okay, that will be. Then how to approach an MRI? When you get an MRI in your hand, how to, suppose if you get an MRI of a cervical spine, how do you evaluate that? So first of all, alignment. You have to look in the alignment of the, as you know, the cervical spine has got a lordotic curve, the thoracic spine has got a kyphotic curve, and the lumbar spine has got a, so look for the alignment of the whole vertebra. The bone, look into the bone, whether there's any fracture, vertebral body destruction, plastic or lytic lesion, etc. Then you should look into the spinal cord. Then you should look into the disc, whether there's a destruction of the disc bulge, etc. Then you look into the soft tissue nearby. So first of all, look into the alignment, then look into the bone, then look into the spinal cord, then look into the disc, then everything else, like actually soft tissues like thyroid, aorta, lungs, etc. So this should be the approach. So as far as an MRI is concerned, normally if you see a plain X-ray, you should draw 4 imaginary lines. One is the anterior vertebral line, posterior vertebral line, spinolaminar line, posterior spinous line. But in MRI, there's no need to draw any imaginary lines because this is the anterior vertebral ligament, posterior vertebral ligament, as well as ligament of flavum. So you have to look into the anterior vertebral ligament, posterior vertebral ligament to see whether there's any step off or not. That means if there is any spondylolisthesis or there, and as well as the ligament of flavum. So first look into the alignment. So this is then cervical kyphosis. Normally, as I said, the cervical spine has got a lordotic curve, thoracic spine has got a kyphotic curve, and lumbar spine has got a lordotic. So in cervical spine, this is the normal curvature. So draw a line from C2 to the C7. So normally there should be arch should be there like this. So this is called as the second MRI vertical. This is called as cervical kyphosis. This is called as straightening of the spine or a military neck. This is called as a reversal of the kyphosis. The vertebra has gone beyond the line from C2 to C7. So normally the cervical kyphosis can happen because of a paraspinal paraspinal spasm, mainly because of some compressed disc into a nerve, which causes a severe paraspinal muscle spasm, which lead to a straightening. Or if there is any, as we age, what will happen? The disc will collapse. As a result, what will happen? There will be a tipping of the vertebrae in front and causes a straightening. Third condition, if there is a aortogenic, suppose doing a surgery or something, if there is a following a laminectomy, etc., sometimes what will happen? It may lead to a straightening of the spine. Or if there is any infection, suppose if there is a port spine, as a result, if some part of the vertebra gets destroyed, it can lead to a straightening. Third is a congenital condition like block vertebra, where 2 or 3 vertebrae will be fused together. These are the clinical conditions where there can be a straightening of the spine. So first look into the alignment of the spine, whether the normal cervical kyphosis is present or not. This under the MRI, you can see there's a kyphosis. Here also you can see. Here there is no, this is a normal spine. This is a kyphotic spine. Let's look into the vertebral body. The second thing, you have to look into the whole. Your eye should follow the uninterrupted cortical margin of each and every vertebral body. Here you can see there's a destruction of the vertebra. Here you can see there is a fracture line over here. In this, if you look into the vertebra, you can see the vertebral end plate is not seen. Rather, there's a hyperintense lesion, a pus formation is there. There is a port spine is there. So you must look into the, but whenever you get an MRI in hand, look for the vertebral bodies. Your eye should follow the uninterrupted cortical margin of each and every vertebral body. Look for any blastic, lytic lesions, etc. Next, after that, you should look into the cervical spinal cord. So normally, as I said, in T2 weighted image, it appears gray in color, and T1 weighted image, it is light gray in color. So look for the spinal cord. So the spinal cord, the normal spinal canal diameter should be minimum 70 mm. Usually ranges from 13 mm to 22 mm. At least normal AP diameter is 17 mm. If it is less than 17 mm, if less than 13 mm, we call it a spinal canal stenosis. If it is less than 10, we call it an absolute stenosis. If it is 8, less than 8, we call it a severe spinal canal stenosis, which may require a surgery. This is how we grade the spinal canal stenosis. Grade 0 means there is no compression. So grade 1 means more than 50% of the arachnoid matter will be compressed. Here you can see more than 50% of the CSF space has been reduced because of a compression. Here you can see the course of the spinal cord. Normally it has got a smooth course. The course has been altered. That is called as grade 2. Grade 3 means because of the compression, there is a spinal cord has been damaged. It leads to spinal to compressive myelopathy. You can see the hyperintense lesion here. That is called as grade 3. That is how we grade the spinal canal stenosis in the MRI. So you know normally why this spinal canal stenosis? Normally as we degenerate or when the anterior posterior diameter of the vertebra will be increased, there will be disc bulge will be there like this. Then the posterior longitudinal ligament will be thickened. The ligament phloem will be thickened, and these structures will compress the spinal cord and causes a myelation or a myelopathy. So when I approach this myelopathy, there are 2 types of myelopathy. One is a short segment myelopathy, and second is a long segment myelopathy. If this is a short segment myelopathy, the clinical indication will be different, because if there's a short segment myelopathy, it could be multiple sclerosis. If it's a long segment, it could be transverse myelitis. So based on whether it is a short segment or a short segment means a single segment. Long segments, more than 2 or 3 segments will be involved. Our differential diagnosis varies based on whether it's a short segment or a long segment. Now this is a case of a compressive myelopathy. You can see the disc has been bulged out and causes a signal changes in the spinal cord. This is called as compressive myelopathy. Compression from the disc osteophytic complex and causes a spinal canal narrowing and causes a signal change. This is called as myelopathy changes. This is again a traumatic myelopathy, and this is a myelopathy following an intraspinal cord bleedage. These are the other pictures. This is sagittal. We can see there's a severe narrowing of the spinal cord lead to we can see a white color of the spinal cord. Not a hyperintense lesion. This is called as compressive myelopathy. This is an axial view. You can see a white color. That's also a myelopathy. This is a coronal view. In the coronal view in the spinal cord, you can see a hyperintense lesion. This is the case of a compressive myelopathy. So this is an axial view of the myelopathy. So based on normally, this will be a uniform in color. But here you can see a triangular defect here. This is called as myelopathy. Here, this triangular type of defect is seen in multiple sclerosis. You can see a triangular shaped defect. This is a case of a multiple sclerosis. But here you can see, instead of a black like this, it has become white in color or hyperintense lesion. Here, this is mainly because of a transverse myelitis, because both the sides, both the right and left side of the cord is been involved, the entire circumference of the cord is involved. It is called as transverse myelitis. It is usually seen in transverse myelitis. Here you can see in multiple sclerosis, a triangular shaped defect in the posterior aspect or in the lateral aspect will be seen. Normally, this is how we see in a patient with the multiple myelopathy is seen in multiple sclerosis in this way as a triangular defect. If it is a transverse myelitis like this, you can see it is the entire circumference of the cord will be involved in transverse myelitis, neuromyelitis optica also. If there is a cord ischemia, suppose there is a ischemia of the spinal cord, you can see a snake eye-like sign in the anterior part. This is the feature seen in anterior cord ischemia. So mainly this multiple sclerosis will be triangular defect will be there. In transverse myelitis and neuromyelitis optica, entire cord will be involved. In spinal cord ischemia, both snake eye sign will be there. If there's a vitamin B12 deficiency, you can see a myelopathy in the posterior aspect like this. This is how it will be seen in the MRI. So based on that appearance, we can differentiate diagnose whether it is a multiple sclerosis, whether it is a transverse myelitis, whether it is an anterior horn ischemia or a vitamin B12 deficiency. Next is multiple sclerosis. As you know, multiple sclerosis is an autoimmune disease where our body's own immune system destroys the myelin sheath of the brain as well as the spinal cord. Here you can see a short segment, a small area of demyelination is there. Suppose if a patient complains of, normally in multiple sclerosis affects the eyes because optic neuritis is one of the main initial symptom of multiple sclerosis. And in such condition, what you have to do, you have to send the MRI of a spinal cord or the MRI of the spine. If you suspect such hyperintense lesions or the demyelinating place in the spinal cord, what you have to do is that you have to send the patient for a MRI of the brain. So in multiple sclerosis, MRI in multiple sclerosis, MRI, the demyelinating place will be seen on the subcortical area, and the subcortical area, periventricular area, in the midbrain and in the cerebellum. These are the and corpus callosum. These are the areas where multiple sclerosis place will be seen if the patient is suspected to have a multiple sclerosis. So, if you doubt about multiple sclerosis, take an MRI of the spine, and in the spine, usually in the spinal cord, there will be demyelinated plaques will be seen. Usually, short segmented plaques will be seen. And if you take an axial view, you can get to see a triangular shaped defect. You can see a triangular shaped defect in the axial. And if you take an MRI of the brain, you can see multiple demyelinating plaques in the subcortical, periventricular, in the midbrain, cerebellum, and the corpus callosum. In these areas, you can expect to get a demyelinating place. This is another MRI of a multiple sclerosis. You can see there is a demyelinating plaque, and demyelinating plaque. In the axial view, you can see a triangular shaped demyelination of the spinal cord. So normally, if the patient is having a repeated attacks of multiple sclerosis, finally the cord becomes atrophied. Here you can see the cord has become atrophied with the short segment demyelinating plaques are seen. That's one clinical condition. Second, in the cord, you may expect to get a condition called neuromyelitis optica. It's also another autoimmune disease where the cause is not known, but a patient can have a autoimmune demyelination. But in neuromyelitis optica, the first part which has been affected will be the optic nerve. You can see the optic nerve is inflamed and edematous. If you take an MRI of the brain, you can get to see the optic nerve is inflamed and edematous. Usually in the MRI brain, there won't be any place in neuromyelitis optica. Very rarely it has been seen, but usually plaques will be absent. Also, usually in neuromyelitic, there will be a long segment demyelination will be there. In multiple sclerosis, it used to be a short segmented, but in neuromyelitis optica, it will be a long segment involvement will be there, with the entire part of the cord will be affected. In multiple sclerosis, only a triangular shape defect will be seen, but in neuromyelitis optica, the entire cord will be affected. So in the MRI, if you suspect whether it is multiple sclerosis and neuromyelitis optica, what you have to do is that you can send for a blood test called the NMO antibodies, neuromyelitis optica, IgG antibodies. NMO antibodies will be positive if the patient is having a neuromyelitis optica. There's another condition of the spinal cord, another demyelinating condition called as acute disseminated encephalomyelitis. Usually it happens following a fever, usually after a bacterial or viral infection or after a vaccination. There will be a inflammation and demyelination of the cord. But in acute disseminated encephalomyelitis, whatever, the entire cord will be edematous and swollen along with the demyelination. Then it will be always a long segmented involvement will be there. And unlike if you suspect a acute disseminated encephalomyelitis, you can send for a blood test called MOG IgG antibodies, myelo-oligodendrocytic antibodies, and that will be positive if you suspect a acute disseminated encephalomyelitis. Next is called as transverse myelitis, or the spectrum of other demyelinating diseases called Guillain-Barré syndrome, etc. Here in transverse myelitis, it will be long segment involvement. Here you can see more than 3 segments is involved, and the whole circumference of the cord will be involved in case of transverse myelitis. Transverse myelitis usually following any bacterial or viral infection. So this is a case of a transverse myelitis. You can see the long segment. There is a demyelination from more than 3-4 segments is there. But usually transverse myelitis recurs over a time, especially with the Ayurveda treatment. The transverse myelitis recover over a time. But if a patient presents with the progressive weakness of the legs, and if you take an MRI and if you suspect a transverse myelitis, you have to send the patient immediately to a center where there's an ICU or a ventilator, because the night time there can be always a possibility of a respiratory muscle paralysis. But initially, if acute cases comes to you, you have to definitely refer the patient to a hospital, higher hospital where ventilator facility, because it will be in the night time. If the patient develops a respiratory paralysis, it will be very difficult to manage in our center. So if you suspect an acute transverse myelitis, because we have to treat transverse myelitis only once the acute phase is over. Then tumors in the spinal cord, there are different types of tumor. One there can be intramedullary tumor, extramedullary, and extradural. 3 types of tumors can happen. One is on the spinal cord, second is outside the spinal cord, and third is outside the covering of the spinal cord. Schwannoma, etc. These are the extradural tumors which can happen. So normally, it is very easy to diagnose a tumor of the spinal cord. But there is one tumor called astrocytoma. It is an infiltrative tumor. It may look like similar like that of a demyelination, but it will be very difficult to differentiate between a astrocytoma, which is an infiltrating tumor. For that, biopsy is required. And second tumors like ependymoma as well as hemangioblastoma, it will be definitely having a features of a tumor, and it is very easy to differentiate diagnosis. But astrocytoma will be always an infiltrating tumor. It will be very difficult to differentiate diagnosis. Then spinal cord ischemia. If there's a spinal cord ischemia, there will be a hyper-intense line on the anterior part of the spinal cord will be there. And in the axial view, you'll get to see a snake eye sign will be there. That is the specialty seen in case of spinal cord ischemia in arterial infarction. And the ventral hyper-intense line will be seen in the spinal cord in the sagittal view. This is a case of a syringomyelia. Suppose if a patient says that he is having a loss of sensation in the back of the body, and he is not able to sense the pain, heat, etc. in the back of the body, because in syringomyelia there will be a cape-like sensory loss in the back of the body with the weakness of the hands and leg, maybe the symptom. So normally if you take an MRI, you can see syringomyelia is nothing but there is a cystic collection in the central part of the cord. This is called as syringomyelia. Hydrosyringomyelia is also another term. This is a patient, actually this patient came for a low back pain, but when I took an MRI, incidentally I found a big syringe which runs from the Usually, serines runs from the C4 to T1 is the area where most of the time serines form. Here you can see there is a dilatation of the central cord. This is called as syringomyelia. In the axial view, you can see the central cord is been dilated. This is called as syringomyelia. There is congenital, acute, etc. Two types of syringomyelia is there. I'll not be going to details. Next is the thoracic spine, MRI of the thoracic spine. So the disease affecting the cervical spine, lumbar spine, and thoracic spine is almost similar, but there are a few notable differences there. One is compression fracture, osteolytic tumors, and infections are more common in the lower thoracic spine. Suppose if a patient, an old age patient or 70 or 75 has got a history of a fall, just fall on the floor by hitting the buttock. Normally, what we will send an X-ray of the lumbosacral spine. No, you have to send the X-ray of a thoracolumbar spine because the most possible common area where a compression fracture occurs is the lower thoracic, T10, T11, and T12, and the upper lumbar vertebra. So, when you refer for an X-ray or MRI, it has to be thoracolumbar spine has to be your choice because compression fracture, osteolytic tumors, and infection usually affects on the thoracic spine. The disc bulge is less seen on the thoracic spine because thoracic spine is having a proper support with the help of the buttressing by the rib cage is there. So disc bulges are very less seen in thoracic spine. But if a disc bulge occurs, it can lead to myelopathy because in the thoracic spine, the spinal cord is very much narrow at that particular site. Here you can see there is a compression fracture of the vertebra. Here you can see the height of the vertebra. Here the height has been reduced. Here you can see the vertebra has been compressed. This is called as compression fracture. This is a T1 weighted image and this is a T2 weighted. But here the spinal cord is absolutely safe because there is no retropulsion of the components into the spinal cord. So in this case, we can easily treat. We have to advise the patient for an absolute bed rest for 1 month, followed by a brace application. Then you can give certain labors, etc. This is called as compression fracture. So whether this is in the MRI one advantage, we can come to whether this is an acute compression fracture or a chronic fracture. This is a chronic fracture because if there is a acute fracture, what will happen? The inflammatory edema will be there. So water appears white in color. If there's inflammatory edema, here also you could get to see inflammatory changes like white hyperintense lesion could have been seen. Here it's black. Here it is a case of a chronic compression. It is not a new compression fracture. That's one advantage in MRI. We can assess whether it is an acute compression fracture or a chronic compression fracture. So this also you can see there is a compression fracture. Here there's a wedge compression fracture is there following a trauma. But this also old compression fracture because there is no, in the T2 weighted image, there is no fluid seen here. So this is also a case of an old compression fracture. Here also there is no retropulsion of the contents. The spinal cord is absolutely safe. This is another compression fracture. Here you can see there is a retropulsion of the contents into the spinal cord. This might have caused a compressive myelopathy and patient might have resulted in a paraplegia. Next is sports pain. So suppose if a patient complains of pain in the lower back, uninterrupted pain, a focal vertebral pain, which does not relieve on change in the direction and it worsens in the night hours, then you have to suspect about the possibility of an infection. If it is associated with the evening rise of temperature, you have to doubt about the possibility of some osteomyelitis, usually sports pain. Here in this X-ray, you can see this is a patient who came to me with the complaints of pain in the lower back. When I saw this X-ray, I had it out. Here you can see a lytic lesion. With the disc here, there's a disc space. Here is no disc space. So I sent this patient. It was a 24-year-old boy. I sent the boy for a MRI scan. This MRI shows a ports spine infection of the spine, a tuberculosis infection. Here you can see a pus-filled cavity, a destruction of this vertebra. End plate has been completely damaged with some extension into the spinal cord. And in the coronal view, you can see a big psoas abscess, more than 300 ml of pus is here. So instead of looking into this X-ray properly, would have done upping or something, what will happen? This would have been collapsed and your patient would have been in a Port's paraplegia. So this is the importance of investigations in our clinical practice. You have to judiciously use X-ray, CT. Okay, what is the role of CT? The CT is Very good if you suspect a bony lesion. If a bony pathology like fracture, a rib fracture, etc., if you suspect, then CT should be your choice. But if you suspect a tumor which causes, infection which causes a compression to the spinal cord, etc., MRI should be your choice. Here, this is called a sports spine. This is another case of sports spine. You can see there is a fluid. You can see the end plate is completely damaged. Disc is completely damaged. There is a pus formation. You can see hyperintense lesion. This is a case of a sports spine. This is tumor metastasis. So normally, MRI is one of the tools which is very good to detect any metastatic tumors. Rather than CT or an X-ray, MRI can detect metastatic tumors very earlier. So there are two types of metastasis. One is osteoblastic metastasis and osteolytic metastasis. In osteoblastic metastasis, there will be hypointense lesion will be there in T1, and in T2 there also it will be hypointense. If there's a lytic, there will be intermediate to hypointense, and in T2 there will be hyper or isointense. So it takes by practice only you will come to know. Here you can see there is a hyperintense lesion and hypointense lesion here. This is from a hepatocellular carcinoma. This is a metastasis from a hepatocellular carcinoma. This is another case of a metastasis from a renal cell carcinoma. You can see hyperintense lesion with a hypointense lesion. That's a case of a renal cell carcinoma. This is another case of an infiltrative tumor from a lungs. You can see multiple lymph nodes, and you can see there is a hyperintense lesion and the bone. This is a case of a metastatic lesion. Next, usually, as we Ayurveda doctors deal more of a geriatric population. Suppose if a patient, an old age patient, complains of pain in the lower back, which is worsening in the night, associated with the fever, evening rise of temperature, and with the recurrent infection like respiratory tract or urinary tract infection, then you have to suspect about the possibility of a multiple myeloma. If you suspect a possibility of a multiple myeloma, first investigation we can send for an X-ray. Here this X-ray shows multiple collapse of the vertebra without an apparent disc space reduction. If you suspect a multiple myeloma, you can take an X-ray of a flat one, either a skull or a pelvis. You can see multiple punched out lesions or a raindrop appearance. This is very hallmark of a multiple myeloma. But multiple myeloma can be better picked because if more than 50% of the cancerous bone destruction happens, then only X-ray can show a multiple myeloma. But MRI can detect multiple myeloma at a very early phase. You can get to see salt and pepper appearance because there will be mixed plastic and lytic lesions. That's a hallmark of multiple myeloma. You can see multiple collapse of the vertebra. You can see multiple collapse with the salt and pepper appearance. This typical salt and pepper appearance is very typical of a multiple myeloma. Then if you are still doubt, you can send the patient for a protein electrophoresis where M band will be seen. This is MRI of that because this is a very important topic for it because we treat more of low back pain. This is an MRI of the lumbar spine. This is a sagittal view. You can see this black what you are seeing. These are the discs. This here, the vertebra is slipped back. There is a spondylolisthesis. This is the disc. This is the thecal sac. This is the facetal joint. These are the facetal joint. This is the spinous process. This is the pedicle, etc. So in spinal degenerative disease, there will be disc lesion will be there, bone marrow changes will be there, ligamentous pathology will be there, the bony changes will be there, spondylolisthesis, cord pathology will be there, and spinal canal stenosis will be there. Now let us see this. Normally, as I said, the disc contains the nucleus pulposus, which is a fluid. So in T2 weighted image, it appears white in color. And the outer ligament is a fibrous connective tissue, which that appears black in color. So normal disc should be in the T2 weighted image. The normal disc should appears white in color. If it has gone black, means it is a case of a desiccation or a degeneration. Because nucleus pulposus surrounded by annulus fibrosis is the normal disc. Here, this is a grade 1 degeneration. It has got a uniform signal. The grade 2 means there's a central horizontal line. You can see, you get to see a central horizontal. That's called as grade 2 degeneration of the disc. In grade 3, there will be hyper intensity in the central part of the nucleus. And in grade 4, low signal intensity centrally and blurring of the distinction between, because here the nucleus pulposus as well as annulus fibrosis, there is no distinction. And grade 5 means complete low signal with no distinction between nucleus and annulus. So these are the 5 grading of the disc degeneration. We call this a desiccated disc. This is called as a grade 1. This is grade 2. Here is a hyperintensity lesion on the center. This is how we grade the disc bulge. So normally, suppose if a patient comes to say that while I was bending or taking water from a bucket, I suddenly felt a certain acute pain in the back. It could be an annulus fibrosis rupture. This annulus fibrosis rupture, in MRI, you can get to see a white dot like this. This is called as annulus fibrosis rupture. There are 3 types of rupture will be there. One is a circumferential fissure, a radial fissure, as well as a rim fissure. This can be seen in the MRI. You can see this is an MRI. You can see. This is a CT appearance. So if you get to see a white thing in the outer surface of the disc, this is called as rupture of the annulus fibrosis. Normally, patient feels a stuck-like sensation while bending down or bending up while lifting, etc. This is mainly because of the rupture of the annulus fibrosis. So normally there are 2 types of disc bulge. One is a disc bulge, second is a protrusion, and third is an extrusion. Disc bulge means annulus fibrosis will be intact. Only there can be a mild bulge of the annulus fibrosis because of the intradiscal pressure is increased. Protrusion means there will be rupture of the annulus fibrosis and a focal area has been protruded from here. How to differentiate between a protrusion and extrusion? In protrusion, what will happen? The base will be having more length than the end. But in extrusion, base will be having a lesser distance than compared to the end of this. This is the difference between a protrusion as well as an extrusion. And the disc bulges in 2 directions, whether it will go up or down. If you go up, we call it a cranial migration. If it comes down, we call it a caudal migration. So disc generally migrates in 2 areas. One is a cranial migration and second is a caudal migration. And also in the axial view, the disc generally bulges in 4 areas. One is a central disc bulge. Absolutely at the central is the disc bulge that is called a central disc bulge. That is very rare because the posterior longitudinal ligament is very strong at this area. So normally disc will not bulge it, but less than 5% there can be disc bulge seen at the central area. Usually disc bulge at the paracentral area. Here the ligaments are not thick at that side. This is called as paracentral disc. This is the central disc bulge, this is paracentral. And third is the foraminal disc bulge. Foraminal disc bulge also less than 15% only. Usually paracentral disc bulge is more. This is called as foraminal disc bulge and this is called as extraforaminal disc bulge. Outside the foramen there is a disc bulge. So these are the 4 types of disc bulge which generally happens. So you can see central disc bulge, paracentral, foraminal and extraforaminal. If it goes up, it is called as cranial migration. If it comes down, that is called as caudal migration. Here you can see this is an axial view. You should study the axial view. It's very important because if you know how to read the axial view, then you can guide the patient whether conservative management is possible or surgery is required, or we can try with our Ayurveda. For that, we need to have a proper knowledge of the anatomy of the axial view. Here you can see the black is the annulus fibrosis. The white is a nucleus pulposus because the T2 weighted image. Why it is a T2? Here you can see the the CSF fluid is white in color. So here you can see the black, these are the spinal nerve, these are the spinal nerve. This is the exit foramina, the nerve exits through. Here you can see there is enough space for the exit foramina is there. This black, what you can see, this is called as a ligamentum flavum. This is the ligament. The normal thickness of the ligamentum flavum should be 3 mm. If it is more than 3, we call it a ligamentum flavum hypertrophy. This is the epidural fat. This is the epidural fat. So this is the epidural of fat. Here you can see nucleus pulposus, annulus fibrosis. These are the nerves. This is the neural foramina. This is the facetal joint. This is the epidural fat. So that's very analog to this. You should have a knowledge about the axial view. Only if you read the, if you know how to read the axial view, then you can command to the patient that this is the exact problem you are having, etc. This is an MRI. You can see, get to see. There is this the disc extrusion. This is because this much of disc is migrate. This is the caudal disc migration or extrusion of the disc caudally. And this bulge or disc has compressed the spinal nerve. This is the very pain sensing spinal nerve. This is the parasagittal view. Here you can see the disc has been compressing the spinal nerves. This is a normal axis will be given for comparison. Here, so normally it should be a P-shaped. This much of space should be there. Here you can see there is a paracentral disc extrusion. The disc has been migrated into the spinal cord, and there is no space for the nerves to, because there is a compression of the narrowing of the exit foramen and compressing the exit nerve root. So if you report this MRI, what you will write at the L3, L4 level, there is a disc extrusion, a paracentral disc extrusion causing a spinal canal stenosis and narrowing of the exit foramen causing a compression to the exit nerve. This should be the reporting of this MRI. See, here the disc is normal, this white. Here the disc has gone black. This is called as a desiccated disc, degenerated. As a part of the desiccation, the disc got bulged out or extruded and compress the spinal nerves. This is the axial view of the same MRI. There's a modic end plate changes. So in the MRI reports, you generally get to see there will be modic end plates. So modic end plate changes, these are all degenerative changes happening on the vertebral body. So type 1 means that is the earlier changes. Normally, this is a smooth vertebral end plate will be there. This is a case of a degeneration of the end plate. Normally in modic type 1, there will be inflammatory changes will be there. So inflammatory changes means there will be fluid will be there. So in T1 weighted image, there will be black end plate will be there. And T2 weighted image, there will be white end plates will be there. So black and white in T1 as well as T2, that is called as modic type 1 end plate changes. In type 2 end plate change, what will happen? The red hemopoietic bone marrow will be converted into red fatty bone marrow. So whenever there's a fat, what will happen? Fat appears white in both T1 as well as T2. Here, in T1 as well as in T2, the end plates appear white in color. That is called as modic type 2 end plate changes. In modic type 3 means there is complete degeneration happens. So the bone marrow has been replaced with a cortical bone. So bones appears black in color. So black and black. So in type 1, what will happen? Black and white will be there. In type 2, white and white will be there. And in type 3, modic end plate will be black and black. That is called as modic type 3 end plate changes. Next is scoliosis. So scoliosis can be better studied with the help of a plain X-ray or a CT scan. MRI have limited role only. It's better. Only MRI has to role if you suspect the scoliosis causes some significant cord compression, then MRI is indicated. So normally, if neurological involvement is expected, then a simple X-ray is needed. There are two types of scoliosis there. This is called as idiopathic adolescent scoliosis, especially in female children. By the age of 11 or 12, they develop a scoliosis. The reason is not known. That's why it is called as idiopathic adolescent scoliosis. While managing a scoliosis, you should know angle called Cobb's angle. So Cobb's angle means a line should be drawn from the inferior end plate of the most tilted vertebra and the inferior end plate of the most tilted vertebra down. And this angle is measured. If this angle is less than 30, we can conservatively manage the patient. If it is more than 30, we have to send for a surgical correction. Especially in idiopathic adolescent scoliosis, the surgery has to be done before the ossification is completely over. So you should know, when you are dealing a patient with the scoliosis, you should know when to refer a patient, when not to. If it is having more than 30, it's better to send for a surgical correction before the age of 18. This is a case of a degenerative scoliosis where the disc has been distracted. As a result, it develops a scoliosis. That's called as degenerative scoliosis. This is adolescent idiopathic scoliosis. MRI will see whether the scoliosis has caused a neural damage or a spinal cord compression or not. Accordingly, surgery or not has to be differentiated. But every doctor should know what is idiopathic adolescent scoliosis, how to make a Cobb's angle. Nowadays, even in mobile, there are apps are there. We will just with the help of a click of an X-ray, we can get the Cobb's angle. This is ankylosing spondylitis. Suppose if a boy of 15 years or in the second decade or third decade, that means in the early 20s or in the early 30s, complaints of pain in the lower back with the severe early morning stiffness, then you have to suspect about the possibility of an ankylosing spondylitis. If you suspect an ankylosing spondylitis, then the second step should be you have to send for an imaging studies. Imaging of the sacroiliac joint should be your preference. You have to for an imaging of a sacroiliac joint. So X-ray can detect sacro. Here this is an X-ray. Here you can get to see sacroiliitis because sclerotic margins on the both sides with the inflammatory edema of the cartilage. This is a later phase of an X-ray where cartilage has been completely damaged and complete fussiness of the joint margin. So sacroiliitis can be obtained from the X-ray. This is a CT scan. You can see there is a rat bite appearance of the appearance is there. That is also indicative of a sacroiliitis. But MRI is the better tool to diagnose sacroiliitis because whenever there's a sacroiliitis, fluid will be up. You can see hyperintense lesion will be seen. The very early sacroiliitis can be detected with the help of an MRI. CT as well as X-ray, it takes little time for that to reflect on the X-ray as well as CT. In ankylosing spondylitis, there will be syndesmophyte deposition all along the vertebra should be there. In MRI, you can see there is a syndesmophyte deposition. There is a bridging between the vertebrae. The whole spine appears as a bamboo spine-like appearance is there. Here you can see. And also there is a, this is called as corner sign or Romanus lesion in X-ray. This is mainly because of an enthesitis, that means inflammation of the site where the ligaments and tendons join on the vertebra. So in any X-ray, if you get to see, they can see a shiny corner sign in X-ray, and in the MRI, you can see a fluid accumulation at the tip of the vertebra. This is called as Romanus lesion, which is a hallmark of the ankylosing spondylitis. Then bridging between the vertebrae should be there. Certain lytic lesion. These are all hallmarks of ankylosing spondylitis. Next is spondylolysis. As you know, if the mother does not take a folic acid during the pregnancy, what will it results in a neural tube defect. It can result in a pars interarticularis fracture or a defect in the pars interarticularis. This is an oblique X-ray of the spine. You can get to see a Scotty dog. You can see a Scotty dog. The neck corresponds to the pars interarticularis. Here you can see the neck is absent. So this is a case of a defect in the pars interarticularis. This is called as spondylolysis. The MRI you can get to see, you can see there is a defect in the pars interarticularis. This is called as spondylolysis. If there is a spondylolysis, what will happen? It results in a spondylolisthesis. That means when there is a defect in the pars interarticularis, the connection between the anterior part of the vertebra and posterior part of the vertebra will be lost. So the vertebra may slip front. This is called as spondylolisthesis. So in grading of the spondylolisthesis, it has been done in 4 stages. If one part of vertebra is slip front, that is called grade 2. 2 part is slip front, grade 2. 3 part, grade 3. This is an MRI of a spondylolisthesis. Here you can see 2 part of the vertebra is slip. This is my own patient, a young boy of 27-year-old who came for a back pain of her wife. He said, I also had a back pain. So when I palpated, I found a step deformity. Sent for an MRI, X-ray shown this. So since it is a grade 2, I sent for an MRI. There is a grade 2 slippage with the pseudo-disc bulge. This is called a pseudo-disc bulge seen in spondylolisthesis. Then I advised surgery to the patient. He has done a surgery and he is absolutely fine. Because a young boy, this will gradually become grade 3 and spinal cord damage and weakness of the legs, etc. can happen. So before that, I advised him for a surgery. This is called as spondylolisthesis. Grading is done. 1 part is different, grade 1. 2 part, grade 2. 3 part, grade 3. This is the L5S1. You can see because of the pseudo disc bulge, the whole of the spinal canal has been obliterated with the bulged out disc. This I had shown you, this is a rupture of the annulus fibrosis. If a hyperintense lesion seen on the disc, this is called as a rupture of the annulus fibrosis. Then in degenerative conditions, what will happen? We can expect to get some degenerative agent. This is called as synovial. This is a facetal joint. Facetal joint, if there is a hyperintense lesion like this is called as synovial cyst seen in case of and degenerative joint disease. This synovial cyst can sometimes compress the exit nerve and causes a pain. So these are the other types of disc bulge. There's a far lateral disc bulge. Next is spina bifida. This is an X-ray of us. Normally, as I said, if the mother does not take a folic acid during the pregnancy, it results in a neural tube defect. The neural tube defects occurs as three ways. One is a spina bifida occulta, which is a minor, spina bifida mylosil, minor, spina bifida meningomylosil. Here, usually we get to get patients with the spina bifida occulta, who usually presents with the low back pain. When you take an X-ray, you get there is a defect here. So this is the normal spinous process. Here you can get to see a defect. In the MRI, visualize the spina bifida better. Here you can see there is a spina where a whole gap is there. So because of that, there's a big spina bifida. There's an adipose tissue over here, and the cord has been attached at this side. That is called a tethered cord. Here you can see because of a spinal cord, spina bifida, the cord get attached here, and this condition is called as tethered cord syndrome. This is a spina bifida result in a meningome as a mylosil. You can see, get to see a mylosil here. Patients with the spina bifida will having a tuft of hair like this, with a fat stranding will be there. So that's about a few discussion about the MRI. Actually, this class, the intention of this class is not to teach you, because within a matter of 1 hour, you can't learn an MRI. MRI requires minimum 8 hours of classes. That too, through online class, it will be very difficult to teach MRI. It is better to have an offline classes, so that minimum of 8 hours is required for you to teach an MRI. The purpose of this is mainly how to, what is MRI, how this MRI images are being taken, what are the views, how to read a general outline of an MRI in spinal disorders, what are the presentations seen in different clinical conditions, just to give an outline. So those who are interested in reading the MRI, they can gradually develop by reading the textbooks. Then I like to say that MRI is much easier than X-ray or a CT. If you learn the MRI, learning MRI is very easy, and reading MRI is much more easier. It is not a very tough subject. The only thing is that we should know the basics of the MRI. If we know the basics of MRI, reading an MRI is very easy, and we can properly guide the patient for any surgery, for any referrals. We should have a good command on the MRI. And the reports of MRI also nowadays are very wrong, because nowadays a centralized reporting centers are there. So from any MRI centers, they will send the MRI film to a centralized area, and they are not responsible to the center, not to the patient. They will look, because they charge for per film. So how much fast they can finish, they will get that money. So we should have, being a responsible clinician, we should have the knowledge to read MRI of our own patients, so that we can guide the patient properly. We can have a better appreciation of the MRI, because we know the clinical condition, we know the physical examination, then we can see the MRI. So we can localize the pathology in an MRI scan, and we can have a better understanding of the clinical condition of the patient. So my request to all the students over here is, you should learn how to read the MRI. It is very easy. It is not that difficult. Only thing is that we are not having a very professional training in the MRI. That's the problem. We could not utilize these tools. But my request to you should start reading the MRI. You should start the basics, so that you can have a better understanding of the MRI. Next is about the sonography. Sonography reading and taking a class like this is not possible, because if I take a class also, you will forget. But I will say how to approach a sonography. Sonography is mainly used in abdominal pathologies. When it comes to the liver pathology, how to prescribe a sonography? You have to always specify that. Suppose if you suspect a obstructive jaundice, you have to write that this is a complaints of jaundice, a USG to rule out an obstructive jaundice. If you write like this, what will happen? The doctor will specifically see the liver, whether there is a dilated biliary radicals or not, and they will report it forthwith. Suppose if you suspect a cholecystitis, you have to refer the patient that USG of the abdomen to rule out a cholecystitis or a cholelithiasis. Also say that please elicit a sonographic Murphy sign, because when we do a Murphy sign, there is a possibility that there can be a wrong appreciation of the result. But with the Murphy sign, sonographic Murphy sign, they can see the gallbladder is coming and touching the probe, and immediately patient feels pain. That is called a sonographic Murphy sign. So if you suspect a cholecystitis, refer USG to rule out cholecystitis, and please elicit a sonographic Murphy sign. Or if you suspect a renal calculus, if there is a pain in the low back, radiating, if a pain in the loin radiating to groin, if you suspect a renal calculus, you have to refer for a sonography like USG of the abdomen to rule out a renal calculus. If you suspect a prostate pathology, how to measure? You have to send that USG of the pelvis to screen for to rule out a benign prostatic hyperplasia. Also mentioned, please see a post-oid residual urine, so that the doctor will take a sonography when the blood is full, and he will ask the patient to void the urine, and then he will screen that how much amount of urine is remaining. If it is more than 50, there is a significant post-oidal residue. So likewise, you need to specify that. Or if a child complains of abdominal pain with recurrent fever, you have to send that USG, a patient with the recurrent fever. USG to rule out any lymph node enlargement or something has to be all right. So whatever is required, you need to write in the sonar. Then only the doctor will focus at that particular area. So that's about the sonography. Sonography uses a sound wave, so it does not have any radiation effect. But the CT has got a lot of radiation. MRI does not have any radiation. MRI is absolutely safer. And CT is usually done to see whether there is any bony pathology. Or CT is also has got some role in analyzing a lung. If you suspect a lung tumor, bronchiectasis, or pneumonia, etc., HRCT of the lung is the preferred choice. Or if you suspect some pathology in the abdominal organs, like sometimes in ultrasonography, suppose if there is a stone occurring in the uretrovesical junction, that will be obscured by the bowel shadow. In such conditions, CT is a better tool to diagnose whether there is a renal calculus is present or not. MRI is not sensitive to that area. Also, if you suspect a bleed, suppose if an intracranial bleed is there, CT is more sensitive to bleeds. But if you suspect a demyelinated pathology, MRI is more good. So likewise, each and every investigation got its own role. So now my presentation just to give you a basic idea about how to read an MRI, how to approach a sonography, and how to approach a CT scan. If you got any doubts, you may ask. And thank you, one and all, for that. And thanks, Chavan sir and other organizers for giving me an opportunity to take a class on the investigations. Thank you.
In stroke,
Thank you very much, sir.
CVA MRI angio is there. So what is significance?
I didn't get you, sir. Can you repeat?
MRI angio for
Yes, sir.
cerebrovascular accident.
Okay, yes, sir. Okay, see, that's another non-invasive procedure. Suppose a patient is having a stroke. If the stroke is mainly because of any thrombus, so MR angiogram will see whether the lumen of the arteries is narrowed or not. That can be better screened with the help of a MR angiogram. But otherwise, you need to put a dye, etc. It's very difficult. MRI can, with the help of a gadolinium contrast, we can see whether the arteries are normal, whether there is a stenosis is there, whether any thrombus is there. If it is there, how much amount of narrowing is there can be detected with the help of an MR angiogram, sir.
Okay, sir. But you have to do creatinine level before doing contrast.
Yeah. See, any contrast, we need to do a creatinine level. But MR gadolinium contrast is comparatively safe compared to the iodine contrast given in CT and X-rays.
Okay. Dr. Chetan, take one by one questions. We'll finish within 2-3 minutes.
Yes.
If you have any question, you can raise your hand, so we will allow you to talk. Please, there is the option to raise the hand. So meanwhile, I have a question. If there is autoimmune pathology, what is the Panchakarma approach for that spinal cord autoimmune?
it doesn't mean that autoimmune pathology. So as far as Ayurvedic treatments is concerned, it depends upon the doshic condition of the particular patient. Suppose, for example, if the patient is having a multiple sclerosis, multiple sclerosis usually it presents as an avarna vada. Kapha avarta avarna is the usual presentation in a patient with the multiple sclerosis. In such condition, Rukshna Chikilsas with the Tikshna Bastis is the line of treatment. But in multiple sclerosis, usually Rukshna Chikilsa Uddortna is carried out, but I don't prefer to do any of the hot bodily things because in multiple sclerosis, there's a phenomena called Utto phenomena. If the body temperature goes above 1 degree or something, what will happen? The condition, the demyelinating condition worsens. So practically, even though Rukshna and Tikshna Chikilsa are told in multiple sclerosis, but usually it comes as a Kapha or the Vada symptoms. But Rukshna Swedanas are not done because when the temperature increased by 0.5 to 1 degree centigrade, there was a worsening of the symptoms will be there. So it has to be a specific case, has to be taken specific condition. Because before the invention of the MRI, multiple sclerosis used to be diagnosed by the doctor suggests the patient to have a hot water bath. After the hot water bath, when the patient's clinical condition worsens, they diagnose it as a case of a multiple sclerosis. So if we follow a typical Panchadharma line of management in autoimmune disease of multiple sclerosis, and if we give some Svedana treatment, what will happen? The clinical condition of the patient worsens. Sometimes in the acute condition, if we give heat treatment, patient can collapse there itself. So it has to be case specific. It has to be a doshic visualization has to be seen. The presentation, because in any autoimmune disease, this is also treatment we can't say. It depends upon the presentation of that particular patient. Usually, it relates into the diagnosis of a Kapha or the Vada. So Rukshna Chikilsas is being given with the Bastis, Rajyavana Basti, etc. is the line of the treatment. I usually do with the Uddortna treatment in all autoimmune disease because Uddortana, that's it gives stimulation of the nerve endings. As a result, there can be neural plasticity because any autoimmune disease which leads to the spinal cord damage, what will happen? There will be weakness of the body or the nerves will be there. So neural plasticity, so the few nerve cells will be died, so the nearby cells has to take up the function of that particular function. So I follow up the treatment of Uddvartana, etc. But in multiple sclerosis, these heat treatments are not being done because of the Utto phenomena. There can be a worsening of the symptoms. Then usually Bastis are my main stay of treatment along with the physiotherapy. Then medicines also, if it is an autoimmune disease, like I usually give like Amarta preparation, Amarta Kashaya, Amarta Ashta, those line I usually go. If the acute phase is over, then I may prefer Bastis like Rajyavana Basti, etc. is my line of choice. I may sometimes go for a Belamula Niruha Basti because Belamula Niruha Basti contains Ashwagandha. Ashwagandha is very good to induce a neural plasticity. And if it is, if some autoimmune disease can present as a Vadarekta symptoms, in such condition, Manjishadi Sharavasi will be the preference. So it depends upon the presentation of the particular patient at that particular stage. It's not specific to a particular autoimmune disease as such, but certain red flags will be taken into consideration, like in multiple sclerosis, heat treatments are not done likewise.
Thank you, sir. If you have any question, please raise the hand. So there is a question answer. There is some questions are there.
May I ask you a question, sir?
Yeah, please go ahead.
So actually, I can understand the fluid. In your book, you showed the fluid shadow, and so it's very difficult to understand gray shadow for this. And we can easily understand, but inflammatory conditions and axial views, I think it require more practice. We can easily understand coronal view, sagittal view in MRI, but in axial view, identifying the pedicle, identifying the facetal joint. So I think it require more practice. Hello, hello, sir.
I think there is some network error. So
I think one should finish. I request let the Shibu get join.
Uh,
Dr.
sir, my
Kendra.
sir, am I audible, sir?
Yes, yes.
Yes,
Okay,
yes,
my,
yes.
my laptop got switched off. I joined from my mobile actually. I didn't hear the question, sir, actually, completely. Can you repeat the
Okay.
question, sir?
Actually, I accepted that it require practice because it's very difficult to analyze axial views as we can easily analyze sagittal view, coronal view, and MRI.
Yes,
But
sir.
in axial view, the pedicle and spinous process
Yes, sir.
and the exiting foramina where compression can be observed. Even the shadow, we can observe the white shadow for spinal fluid and other also. But fluid and the blood fluid, their shadows are different.
Yes, sir.
So I
Yes, yes,
think
sir. It requires some practice, sir. But it's very easy. Actually. It's not that difficult as you think, sir. Reading MRI is very, very easy. Rather than an X-ray, MRI. Once you study the basis, once you study the anatomy and where this structure comes, and if there's a pathology at that particular site, what will be presentation? We study. It will be very easy to read, sir. Actually, then the distinction between the fluid at where it comes, it depends upon the anatomical location of that particular subject, sir. But it will be very easy. It will be very easy to differentiate, sir.
even the
Actually.
subdural fat
Yes.
and the shadows are different.
In such question of a doubtful condition, there is an image called the fat suppression image. Many times, actually, whether it is a modic end plate changes or an inflammatory pathology, if we suspect, then we go for a fat suppression image or a stir image, sir. In that, fat will be suppressed, so we can come to know whether it is a fat or an inflammatory food. That is called the fat suppression images are available, sir.
Okay, sir. Thank you, sir. I request Dr. Kendra, please
Sir,
give vote of
before
thanks.
before vote of thanks, I would like to request Dr. Shubhu Varghese sir, please throw some light on sports injury and role of CT and MRI, sir.
Definitely, in the sports injury, MRI plays a vital role. CT, as I said, CT is very sensitive only to bony pathologies. If you suspect a bony pathology like a bony fracture, CT is the best thing. But if you suspect a soft tissue injuries like ligament, so for example, if you take a knee, if you suspect a knee fracture anywhere, CT is good. But if you suspect a meniscal injury or a collateral ligament injury or a cruciate ligament injury, MRI is more good. So, depends upon the nature of the injury. If you suspect a soft tissue injury, MRI would be the preferred tool. If you suspect a bony injury, CT would be the better tool. But MRI can visualize a bony injuries as well as soft tissue injuries as well. So, MRI is the preferred tool. For example, in the knee, if there is a meniscal injury, it will not be seen either in the X-ray or in the CT. It will be shown only on the MRI. If you suspect a cruciate ligament injury, how much extent, whether it's a high-grade tear or a low-grade tear, complete tear, if there's a retraction of the ligament, it requires an MRI. So for any sports injuries, MRI is the best tool to be used.
Okay, sir. Thank you, sir.
Okay, sir.
Santosh sir,
Dr.
shall I
Vaibhav is
proceed?
there. Yes.
Hello.
Hello.
Yes, sir. Continue, sir.
Okay. Thank you very much, sir. At last, I take this opportunity and it's my privilege to convey my vote of thanks. Uh, I I would like to convey my vote of thanks to today's guest speaker and esteemed person, Dr. Shibhu Varghese sir, professor and even Senate member, University of Health Sciences, Kerala, for your wonderful deliberation, sir. It was actually indeed a need of hour. As new NCSM syllabus, almost all you have covered all the points. On behalf of Vishwa Ayurveda Parishad, wholeheartedly I convey my thanks to you, sir.
Okay. Thank you, sir. Thank you, sir. Nice.
And similarly, I'd like to convey my thanks to the office bearers and even Vishwa Ayurveda Parishad members. First, I would like to convey my vote of thanks to Professor Govind Sahai Shukla sir, President Vishwa Ayurveda Parishad. And I convey my vote of thanks to General Secretary Professor Mahesh Vyas sir and Organizing Secretary Professor Yogesh Chandra Mishra ji sir. And I would like to convey my thanks to National Convener Professor R.K. Gupta ji sir and National Co-Convener Professor Santosh Chavan sir, Coordinator Professor Chetan Gulane sir, and all the zonal coordinators and esteemed delegates who have shown your patience throughout this session. Thank you, one and all, sir.
Thank you. Good night, sir.
Thank you, sir. Thank you. Sir.
Thank you, Singh. We declare that the session is over. Thank you so much, sir. Okay, bye.
Thank you, sir. So I have shared the feedback form also. Please give the feedback. Thank you.
Okay, sir.